This conference will now be recorded.
All right, folks, very good. So I'm glad you're all here this evening on this cold, wintry day, and we are going to start looking at our first PowerPoint of the semester regarding the nervous system and finishing up the nervous system over a couple of PowerPoint chapters here, and we're going to be looking at special senses right after we go through and look at this integration of the nervous system functions. So a sensation. So we already have this foundation of understanding regarding that the nervous system has sensory receptors that will have or receive input. Okay, the sensory input, we would say, recall these terms afferent and efferent. I don't want you to forget that, so you need to know that and realize that sensory input is afferent information, motor output, right, is efferent information. So recall those. Remember that. These action potentials are is really the information that's being traveled from the neuron cell body out through the axon, right? That's the action potentials. Graded potentials are sending information via the dendrites to the soma, the neuron cell body, and then the axon carries action potentials. Okay? So special senses we'll be looking at in the next chapter. Your sense of vision, right? Your sense of hearing, olfaction, your sense of smell, gustation, your sense of taste, and your sense of balance, right? Balance and equilibrium have a lot to do with what's going on in the inner ear as well as your cerebellum. So general senses. So when we're looking at somatic dealing with the body or visceral dealing with the organs, we can experience pain, pressure in the organs. How about if an organ is expanding, right? In the case of, say, like the urinary bladder, and a patient has had a procedure for their prostate gland, and not prostate, right? The prostate gland, and the patient is not able to void. So what's happening then is that they're not able to void. They need to be catheterized because their urinary bladder will fill, and to the point where it can burst, and that's an emergency and a major problem there, because the kidneys are continually. You're going to find this out and see this. The kidneys are continually filtering blood, producing filtrate, and what's the less than 1% or so that of that filtrate that's being produced that actually is not being reabsorbed, but actually sent via the kidneys to the urinary bladder, and that should be voided. It's going to continually being produced, and so we have to make sure that we're allowing for that ability for it to leave the body via voiding. You'll see here as far as from the body, so pain, pressure, temp, touch, proprioception. We're going to go into the details regarding the terms as far as what we're seeing here. So sensory receptors, right? So we have these exteroreceptors, right, that are on the integument, on the skin. The visceroreceptors, right? Viscera, we're thinking organs, so visceroreceptors for the organs. Proprioceptors present within the joints, right? And so these proprioceptors present within the joints will help us to have an idea. Even when we have our eyes closed, we can still have parts of our body in different directions in different areas, and yet we still know what's going on with our body parts as a result of the input from those proprioceptors. Okay, photoreceptors, thermoreceptors, mechano, chemo, noci. So nociceptors dealing with pain. So when you hear that term nociceptors, think a pain type receptor. Photoreceptors, think as far as light, right, for vision. Thermo, think temperature, right? Mechano, think movement. Chemo, think chemicals, right? So, and involved in our sense of smell and taste, right? Mechanoreceptors for the hearing and balance and such. And so we're going to see how special senses and other areas of our nervous system that are receiving information, how unique they are and how fortunate that we have them. Folks, there's an illness called Hanson's disease, right? Hanson's disease, you might know it as leprosy, okay? And so this illness attacks the peripheral nervous system, and it can affect the ability for a patient to really have any type of sensory input whatsoever from any part of their body. And what can happen then is that parts of their body can be damaged to the point of infection and damage where they end up having gangrene, and parts of their nose and face gets destroyed, as well as their extremities. It's a horrible, horrible illness. Now, know that it's a bacterial infection, and so it can be cured, whereas years ago, they had colonies of patients for leprosy that they would just go and really pretty much wither away and die, and very sad. Also very similar to, you know, the ability that we have to use antibiotics is amazing. There were, in New Jersey and other areas of the country, we had different types of facilities that were just meant for patients with tuberculosis to just go and pretty much live as much of a life as possible before they die, and not being able to spread it to their family members prior to the advent of antibiotics. So really, it's amazing, folks. Antibiotics, the great things that they can do, the abuse of them, not so good, right? And the adaptation that takes place of the microorganisms to the antibiotics as a result of the abuse of them is a shame, because the antibiotics are just a remarkable thing. The ability for us to do surgery and have patients have a positive outcome and not get, you know, illnesses and infections that will kill them as a result of us being able to use antibiotics is remarkable, folks. It's just really, it's a miracle drug. It really, truly is. But like I said, any type of treatment, any type of medications that we take, any types of whatever it may be that we're taking into our body, we need to make sure that we are telling our patients that there are, you know, possible side effects, right? And many times it's minimal for many different types of treatments and drugs, because we've had testing done, many testing done over the years. But you know, things still happen, folks, and so there are still, you know, medications and drugs that are taken off the market because they've found out that they can cause other problems that are not beneficial, because the cost to benefit ratio, it doesn't make any sense. There's too much of a risk involved, and then that's when they'll pull a drug or anything off of the market, their treatment. So just getting back to our situation, so it's very important that we as a healthy body have the ability to sense any type of input coming into our bodies so that we can respond to it. Free nerve endings on the epidermis, and we'll see this as you saw this in last semester as far as the integument and how close it was. These free nerve endings were present within the dermal papillae, really right underlying to the epidermis. You'll see here as far as Merkel disc, Meissner's corpuscles there. Again, whether something is very close to the surface of the skin, close to the epidermis, you know, then we're talking about light pressure, light touch. Whereas if something is very deep into the dermis, then the dermal layer, and closer to the hypodermis, then we're looking at more deep touch and pressure. Meissner's corpuscles for the ability present within the dermal papillae for 2-point discrimination, and depending upon where and the proximity of these Meissner corpuscles. So like say on your fingertips, they are very close together so that, you know, you really can have, there are devices that we have them in the lab that we'll be looking at. They have like 2 little pinpricks, right? Two little points, and you can separate them like a caliper, okay? And you can separate them or bring them close together. And the closer that we have these Meissner corpuscles together, like say on the fingertips, where we can really differentiate stuff, input very, very finely tuned on our fingertips in comparison to other areas of our body, say like the skin of our thigh, okay? Much different. So 2-point discrimination and just the ability to have more of a fine tuning on our fingertips in comparison to other parts of our body as far as our sense of touch. Very fascinating. Ruffini end organs, hair follicle receptors. This is interesting, right? So that, you know, understanding that, you know, now in my family, we have quite a bit of, you know, body hair and such, and it is what it is, and you know, what are you gonna do? But it's not something that's, hair on your body is not meant to make you warm per se, right? You know, like a bear and we're looking at a dog, right, that has hair and fur, that's meant to keep them warm. Hair on our bodies, right, when we have a bug or something that's walking along our integument and it moves the hair follicle, the hairs themselves, we have these hair follicle receptors present within the dermis that are able to detect that movement and tell us, hey, I got something on me. You know, whether it be a bug, whether it be a snake, whatever kind of a thing it could be on us, can give us an idea, sensory input. Hey, check out and see what's on you so that it's not going to hurt you. As far as the touch and pressure, again, these many different types of touch and pressure receptors present, more superficial or deep within the dermis. These Pacinian corpuscles, aka known as lamellar corpuscles, they're more deeper located. Ruffini would be more like mid area of the mid region of the dermis. As far as in skeletal muscle is concerned, so the Golgi tendon apparatus, the organs here, and the muscle spindles. So very important as far as for present within the tendons, as far as it says there in Golgi tendon, right? Responds to change in muscle tension. And this can really be helpful as far as protecting damage of skeletal muscle by too much of a load, right? Too much of a heavy weight or burden that it prevents you from truly causing major muscular and tendinous strain. Okay, strains are tendons, muscle, sprain, ligaments. Recall that, right, from last semester. Muscle spindles. These are involved in the stretch receptors, involved in the stretch reflex. And so recall we did where we checked the patellar reflex and such and showed you how that worked and such. And we went over that at the end of last semester. So getting back to the proprioceptors, okay? So this proprioceptor is very important as far as for involved in position sense and movement and such, your range of motion, ROM, awareness of a body and where it's located even though your eyes are closed. I mentioned that and demonstrated that earlier there. And you're gonna see as far as tonic and phasic, I wanna go to the next slide here. And so with tonic receptors and phasic receptors, tonic are slow adapting, phasic are fast adapting. And you can see like phasic and fast kind of go together, so help to kind of click it in your mind a little bit as far as having them correlate with each other. Okay, and so that in particular with the proprioceptors, the tonic receptors allow for that situation as far as knowing body position with the eyes closed, nociceptors and most proprioceptors, right? So the nociceptors, we think what? Pain receptors, and the fast adapting are these phasic receptors. So something that's fast adapting. So knowing position of body part as it's moving, pressure, touch, olfaction. So start with olfaction there. You're in a room and you smell a good odor or a bad odor, right? Well, over time, as you smell whatever odor it is, you kind of get used to it, right? Your body adapts to that sensation or that smell. Now, in the case of healthcare, there are times when we've had patients that have had just really bad odors as a result of poor hygiene habits, and so bad that your body just doesn't adapt to it, and it's just even to the point of where even after the patient leaves, that odor still like lingers in your office and so cleaning. And I have to tell you one thing that even just the silliness of that we, not the silliness of it, that we have to wear the mask. I get that. We understand that it's protective. It's important. Absolutely. But, just that we have these masks, even like when we're using facilities that there might be bad odors, it's not such a bad thing that it helps a little bit with that. And then pressure, touch. How about, we're wearing clothes, right? And, when you initially put on a piece of clothing, whether it's a shirt or pants, whatever it may be, you notice the sensation, but you don't notice it for very long, because your brain adapts to that sensory input and doesn't like allow you to keep it in mind, except when I mention it, then like you kind of maybe think about it a little bit. But but isn't that funny though, how you're not thinking about your socks or your underwear or your shirt or your pants, you're just not thinking about that because involved in those phasic receptors, they're fast adapting. Okay, yeah. All right, so as far as this is important, I want you to know, so again, we talked about pain receptors and their nociceptors, right? Acute and chronic. And I think that you have an idea and an understanding of this as far as an acute injury. You know, you fall, you're involved in some type of sport injury, or you're in an auto accident, or whatever else kind of thing, right? Provoked by a specific disease or injury. Serves a useful biological purpose in that it's associated with skeletal muscle spasms, sympathetic nervous system activation, self-limiting. So really, like acute pain, it's usually just something that's short-term. Chronic pain, sadly, right? So in my business, I worked with patients in acute pain who came in hunched over or with assistance. Really, it's a little scary, to be honest, I have to tell you. Initially, as you're young in practice, working with patients who are in severe acute pain. But you kind of get used to it and work to help them. And it's really exciting to be able to help a patient in acute pain who is hunched over, doing some treatment and allowing them to feel some relief and be able to move better and ambulate and have less pain. That's a beautiful thing for sure. The chronic pain, so this is pain that persists, and this can be, after some months of this type of pain. In contrast, considered a disease state, chronic pain, pain that outlasts the normal time of healing, if associated with disease or injury and such. And so, yeah, so acute and chronic pain difficulty, and we're seeing that in our society. We've been seeing that for the past years there regarding the whole epidemic regarding the different types of analgesics that are being abused and such, right? And prescription medications that have been abused, and really trying to go back to really limiting access to those medications because they're not wonder drugs. They really do ruin people's lives. There's some videos online on YouTube that I think I'll look up and maybe share with you all to look on your own regarding patients who are prescribed these strong opiates, and initially what a blessing they were, but then what a curse they became when the patients developed a dependency upon them, and how sadly it ruined their lives. Really, really sad. And I can tell you, I have quite I have a lot of sympathy for patients and for people who deal with chronic pain. It's hard. It's a hard life to live, folks. And when different treatments for whatever reason don't really work, don't really make a difference for them, or very little difference, you can understand how desperate someone can become in wanting to not be in pain. Yeah, it's easy just to say, oh, those people, they're addicted, they're just a bunch of druggies and addicts. And no, understand that there are many people who have gone down that path only because of the sadness that their life has become as a result of chronic illness and chronic pain. So you'll see here, and some chronic pain can be associated with psychological dysfunction. Absolutely. Phantom pain is a very interesting pain. And we've seen this as far as soldiers coming back from the military as a result of losing limbs and such. And so even though maybe they don't, and I've had patients with missing digits and missing parts of their body, whether it's upper or lower extremities, and whether it's a foot or a lower portion, lower leg and foot, and they can still have pain distal to that, where that limb used to be, and that's just a brain situation, a neurological situation. Excuse me one moment. Thank you. And so they'll do different types of therapy, like mirror box therapy. Cool stuff. So say I'm missing my left upper extremity, right? Say from the elbow distal, okay, it's gone. And what we can do then is we can have a mirror on the left side here, and I can use my right extremity, upper extremity is still there, and I can look we can have the patient looking in the mirror as they're manipulating and moving this right arm and the intact limb, and as if it were the missing limb, and it helped to really work to make connections in the brain, in the pathways there, in order for them to see that, hey, it's, like they trick the brain, re-educate the brain into thinking that that part of the extremity is still there. And there's many things that they can do with this in order to help the patient manage and even eliminate phantom pain, okay? Referred pain is quite interesting. Look at this here, as far as a sensation perceived in an area of the body that is not the source, right? So we all know regarding a heart attack, if a patient is describing and complaining of jaw pain on the left side, pectoral region or the left arm, chest, and as far as in the mediastinum here, these can be areas that can be associated with the heart. Liver and gallbladder we can have associated with the right shoulder. And so it could be that the right shoulder is not having a musculoskeletal issue, but it's that pain coming from the liver and the gallbladder that could be referring to that area. Now, this is interesting. This is a very interesting statement to make here, and I want you to think about this for a moment. So everyone perceives pain at the same intensity, right? But we all tolerate it in different ways. So understand, it's not that everybody has different pain intensities. No, we can still have the same type of intensity from an injury, and we can have two people can have the same type of injury, sending the same signals to the brain, but I may be able to tolerate that intensity better than you, just genetically, and it's hard to understand why. So if a patient states that they are sensitive to pain, they probably have a low pain tolerance, right? Not a low pain threshold. Okay? And so genetics are involved in determining that and such. And also, you'll find this also with as far as medications are concerned, and the actual toleration of medications. Some patients need more of a medication to make a difference, and that's not the norm, but that can occur. Okay, as far as, like I said, with the analgesics and such. Now, let's see here. Good. All right, so you recall as we look at this image right here, so we're going to be reviewing this in the lab and going over it as far as the different structures and such. But how about let's look at the all right, so here we have an image, and you're seeing here, so frontal lobe including this precentral gyrus. The central sulcus is the line of demarcation for frontal lobe, parietal lobe, postcentral gyrus, posterior to the central sulcus is the parietal lobe, occipital lobe, temporal lobe, cerebellum, right? Pons, medulla oblongata, spinal cord, right? So just recall this, and so back to here, okay? So then as we're looking at these next few slides, so you see here as far as, so somatic sensory cortex, so the sensory input, okay? Remember that sensory input, except for the sense of smell, olfaction, is passing through the thalamus, okay? So you need to remember that, right? So as we look at, okay, next image here, again, that's why I was going to the sagittal. Okay. So recall that, so this region right here, the third ventricle, this contains primarily, it's the thalamus. Anterior to that would be the hypothalamus, but third ventricle, the thalamus. And that's the area where sensory input will relay through, it's the relay station, and then go to postcentral gyrus, right? The somatic sensory cortex, okay? The homunculus, size proportionate to the number of receptors. So it's a weird looking thing. I showed it to you last semester. I won't show it tonight, but we'll look at it next class just as a review. You'll see here, as far as you need to review these, as far as the cortexes are concerned, the cortices, as far as the frontal lobe, temporal, postcentral gyrus for the gustatory cortex, your sense of taste, right? Visual cortex, the occipital lobe, auditory, sense of hearing, temporal lobe, which would make sense, and then olfactory, sense of smell for the frontal lobe, because remember, right? So we're looking at those coming through the cribriform plate of the ethmoid bone. You'll have the extensions of the olfactory bulb, and those extensions passing through the cribriform plate are what are covered in a very thick mucus and allowing for your sense of smell. We'll talk about that in the sensory in the special senses chapter for your sense of smell. Now there are association areas. These are areas that are not the specific area for a certain function, but they work in conjunction with, okay? So somatic sensory association area, posterior to the postcentral gyrus, which is the somatic sensory region, cortex. So this area posterior to that will work in conjunction with the somatic sensory cortex, and it's called the association area, as well as we'll have for the visual and other areas that are, what does it say here? Integrate incoming sensory information, as well as form connections between sensory motor areas. And know that also in the frontal lobe is regarding your motor functions, that there are association areas also working in conjunction with the precentral gyrus, that primary motor cortex. But we're looking at sensory right at the moment. So you'll see here as far as sensory nerve tracts, okay? So know that this is important. I've highlighted here as far as the nomenclature. So action potentials from the body to the central nervous system. So sensory, right? So it's sensory input, afferent, AFF-ERENT, sensory input coming to the CNS, coming to the brain spinal cord. And so they are named, right? The nomenclature, how we call these. So you see here, spinothalamic. So first part of the word is the origin. The second half is where it is terminating. And so terminating in the thalamus, terminating in the cerebellum. That would be as far as understanding that for spinal cerebellar, spinal thalamic, the DCML, as far as dorsal column, medial lemniscal, dealing with, and so as far as the portions of the spinal cord, understanding where these tracts that are going up, they're afferent, they're going into the spinal cord and coming up to the brain itself. Okay. And you'll see here as far as, so I want you to know these, right, in yellow, the DCML, spinal thalamic, spinal cerebellar, as far as for unconscious proprioception for spinal cerebellar, pain, pressure, itch, tickle, all associated and very similar as far as presentation and as far as input to the spinal thalamic. The DCML, as far as for touch, 2-point discrimination, we talked about that right in the fingertips. Pressure, proprioception, vibration, these are all very similar in their input, and they travel on the DCML. As far as skeletal muscle control is concerned, okay? So skeletal muscle, we have conscious control, right? And so think that there are 2 neurons involved in voluntary muscle control, upper and lower motor neurons. And you've even heard of like, oh, they have an upper motor neuron lesion, lower motor neuron lesion. You might have heard that before. And so this is what we're referring to. So an upper motor neuron, direct control over inner neurons. To the lower motor neuron, this is more present within the central nervous system, neuron cell bodies in the cortex. Lower motor neuron lesions, right? Axons leave the central nervous system to the skeletal muscle via the peripheral nervous system, neuron cell bodies in the ventral horns of the spinal cord. Okay? So upper motor neurons, upper and lower motor neurons. Now, when we think precentral gyrus, this is anterior to the central sulcus, right? We're looking at primary motor cortex. Okay? And again, this primary motor cortex, the precentral gyrus, anterior to that, we have the premotor cortex. We have, and anterior to that would be the prefrontal cortex. These are all association areas working in conjunction with the primary motor cortex in order to be able to perform certain functions that we actually consciously control and can do with our skeletal muscle. Okay? So conscious movement, this is cool. So you'll have here, as far as initiation of the movement in the premotor area, right, anterior to the precentral gyrus, stimulation of an upper motor neuron. The upper motor neuron axons form descending tracts, leading to the lower motor neurons, which are going to then go out to the peripheral nervous system, via the peripheral nervous system to the skeletal muscle, and allow for contraction to take place. Okay? Basal nuclei, the cerebellum, all involved in this, planning, coordination, execution of this voluntary movement. So really damage to the cerebellum. So you remember we talked about this as far as temporary damage can take place as a result of taking drugs or drinking too much alcohol, right? Alcohol intoxication can damage temporarily the cerebellum, and this can lead to your not really ability to have good conscious skeletal muscle control. Oh, excuse me one moment. Oh, sorry, just a phone. Okay. All right. So really important. So you should commit this to memory as far as what I've highlighted here. Very important as far as knowing the steps as far as premotor, upper motor neuron, descending tracts, lower motor neuron going to the skeletal muscle. And knowing the importance in particular of the cerebellum as far as working with the precentral gyrus, as far as they have the ability to control what takes place as far as skeletal movement is concerned. All right, so I think we're going to stop here as far as, let's see, so action potentials from the CNS to the body, right? These are motor nerve tracts. And we know this as far as that we studied as far as when we're looking at skeletal muscle contraction, we showed that we have an action potential traveling down the axon to the skeletal muscle, and really there's an interaction there as far as that area where we're having the axon terminals, right, not touching, but interacting with the motor end plate and allowing for neurochemicals, so those acetylcholine in particular, neurotransmitter passing over the junction there, the space, right, where we have that synaptic cleft, and then allowing for then issues to take place, action to take place within the skeletal muscle, and leading to the actual cross bridges occurring between actin and myosin, and allowing then for sliding to take place, so that we have that sliding filament theory taking place, right? So very important as far as skeletal muscle contraction is concerned. And we'll see here as far as the term pyramidal and extrapyramidal pathways. So remember that pyramidal have to deal with direct pathways, so muscle tone, skilled movement. So know that as you're all sitting here watching what's going on as far as this class taking place, that you're not just slumped over, right? No, not at all. You have some form of tone to the musculature that is actually the postural muscles that are supporting you. Think in terms of then the pyramidal pathways are doing this. There's a direct connection there, a direct pathway. As far as the extrapyramidal pathways, it's an indirect, dealing with more of the imprecise movement, whereas skilled movement, fine motor skills, muscle tone, pyramidal pathway. All right, folks, so we're at 22. We'll finish up the last 11 slides next class, and then we'll also review and go over and start getting into special senses. Okay, so I'm going to stop recording.